Now here to talk with us about the gastrointestinal cancer data that is being presented here at the meeting is Dr. Ghassan K. Abou-Alfa, who's an attending medical oncologist at Memorial Sloan Kettering Cancer Center. So welcome, Dr. Abou-Alfa. Thank you so much for being here today.
Thank you, Gina. Great to have you. Thank you.
So let's talk about some exciting, intriguing data that's being presented in GI cancers at this year's meeting. What are you really excited about?
So no doubt that this ESMO is really full of quite exciting data, and if anything, we might probably focus on the things that I mainly pay most attention to in regard to the research which we do at Sloan Kettering. And I would say that probably on top of the list is cholangiocarcinoma, a rare cancer in a way, but nonetheless is getting a lot of attention, especially with the advent of a better understanding in regard to its genetic makeup. And no doubt that FGFR2 has been really quite exciting at different meetings, among which is the ESMO 2018.
Now let's go a little bit more into FGFR2. So what's exactly going on there in cholangiocarcinoma?
So no doubt there are actually two presentations. One of them is on the infigratinib, which is the BGJ that's also known for people by that name. And if anything, it's a further update on the data that was really provided for patients with the FGFR2 fusion or any other potential fusion. And if anything, exciting report of a close to about 31% response rate. So no doubt great information, and at the same time a better understanding about the management of the drug per se. On the other hand, there's another report which is really definitely quite exciting that I'm honored to be heavily involved in, which is on the INC B054828, what's called the Flight 202 study, which again was divided into three cohorts based on the FGFR2 fusion, any other different fusion, or all comers without the fusion per se. And for the FGFR2, impressive response of close to 41% response rates. So no doubt that this category of drugs has potential moving forward in regard to cholangiocarcinoma, and if anything, it's really further question is how it's going to be defined further. Would it be again limited to just phase 2 data and based on response, or would it need a randomized phase 3 trials? This is something that of course we would like to see how it's going to evolve.
It sounds very encouraging. Now, what about in metastatic pancreatic cancer?
So pancreatic, no doubt we've been hearing quite a bit in the last several years, and sadly at this ESMO 2018 we understand and we hear that the CARRY trial, which involved the IGF-1, which is esitrumumab plus gem plus nab-paclitaxel versus gem nab-paclitaxel, sadly was not really revealing any further improvement in outcome. If anything, and it was a rather large study, 370 patients or so, and if anything, the overall survival was for the triplet 8.9 months, while for the doublet 11.7 months. If anything, it really reprove and show again the impressive efficacy of the gemcitabine plus nab-paclitaxel, which is already approved as a standard of care for the disease. But at the same time, it shows clearly that there is no added benefit from the esitrumumab and the IGF-1, which also the authors, Dr. Ko from UCSF, mentioned that there's no adverse addition that the IGF-1 does contribute to that. What I like about that abstract, if anything, despite, of course, we always wish for positive data, but I'm really impressed, and of course, I know this team extremely well, but Dr. Ko and his colleagues are really saying that it did not really change outcome. This is really what we need to hear, rather than the words promising and maybe and what have we. They were very straightforward. Good for them. There's great effort on their part.
Definitely, great points. Now, of course, liver cancer. How about some new findings or what's being talked about here at the meeting?
Oh my God, the liver cancer, I'll tell you, like I've never seen any cancer literally with that much information evolving so fast within barely, we're like only a year and a half or maybe close to 2 years. We moved from one drug 2007, which is sorafenib. Now we have literally 3 fully approved drugs in the FDA, being sorafenib, of course, regorafenib as second line, and lenvatinib in first line. On top of that, there's a conditional approval for nivolumab. I have to say, and this is really just what everybody was hopeful, is that there will be some data on nivolumab versus sorafenib, checkmate 459 at this meeting, but no, there isn't. However, if anything, there's a further rehash on one of the TKIs, which was reported lastly at ASCO as well, which is the REACH2, which is looking into ramucirumab, which, if you recall, in REACH, if you want to call it REACH1 or the REACH study, was negative. However, in REACH2, it appears to be that there is a potential for a benefit in patients with alpha-fetoprotein more than 400. And if we recall at that time, the improvement survival for the patient who got the ramucirumab with AFP more than 400 was 8.5 months versus those who were on placebo 7.3 months. So that benefit was definitely there. Interestingly, in retrospect, and understandably because the eligibility criteria were similar, of course short of the AFP level, but however, because they can define from the REACH study the high AFP patients, they combined the two studies in further analyses. And at that meeting, as I understand, they reported the further analysis in regard to the patient-reported outcome based on the FHSI-8, and they really said that there is no difference at all, or they didn't find any difference at all in regard to the two studies or the combination of. I would say this is a nice effort, but I would say we're still eager to see the full data, hopefully in a manuscript form, so we can understand better if really the alpha-fetoprotein is a true prognostic factor. What is it? Because truly this is still not further defined short of this nice positive data.
Great. Now, anything else in liver cancer that you're really excited about coming up in the future?
I would say that liver cancer at the moment evolving really in different paths, among which TKIs, I think quite a bit of information that already we heard quite a bit about, and I would say with literally 5 agents on board, it's a matter of like who's going to be first, who's going to be second. We're not sure yet. It's going to evolve a little bit further, I would say. On the other hand, the bigger item is the checkpoint inhibitors, and obviously nivolumab versus sorafenib, we're waiting for the data. Pembrolizumab versus the placebo in second line, we're waiting for the data. Short of that, we have data for the phase 2s of those two drugs. In addition to that, the big item is Himalaya study with the combination of the durvalumab plus tremelimumab in a randomization of 4 different options, being durva-trami in 2 versions. This will make 2 lines, and then lastly sorafenib. That's quite exciting. And of course, one more thing is the combination of TKIs plus checkpoint inhibitors, as we heard from the atezo plus bevacizumab. I would say this is interesting, exciting, but still we don't have enough data to analyze it per se. Remember that the response rate that was reported at 70% was based only on about close to half of the population that really made it to the 16 weeks to be evaluated for the response. And as such, I would say interesting, but we need the science to really prove it further. And at the same time, we need to see further analysis that really will show for us if really there's a real story there or not. I would say, however, been there, done that kind of thing for the TKI checkpoint inhibitors. I would say that the vision and the high focus that we are heavily involved in now is CAR-T. We'll see where it's going to take us.
Wow, sounds like there's a lot on the horizon.
Hopefully.
Great. Well, thank you so much for being here today, Dr. Abou-Alfa. We really appreciate it.
Thank you so much, Dina. Always really nice to be here. Thank you.
Thank you.
Thanks.